Hey, good morning. This is Stites, Chief Medical Officer at the University of Kansas Health System, broadcasting live with you from the Dol Simons Family Studio, and delighted to be back with you today on this beautiful Friday morning when the temperature is going to be 50 degrees. It's going to feel like an early spring day. Don't worry, there'll be more winter on the way, but it's going to feel really good out there today, Hawk.
Yeah, the moon was pretty this morning.
Oh my gosh, was it great? I drive from east to west, and the moon was just hanging out there in the sky. I think that's a good sign for us, at least I hope it is. How do we do overnight?
You know, we're still pretty good. We're still down near that century mark of total patients in the hospital. Only 50 active acute patients in the hospital.
I love that. Man, won't it feel good to be in the 40s? It's coming.
Yeah.
It's coming.
Yeah, we know that happened. After the New York surge, after they had recovered a little bit, there was some hospitals that had no COVID patients in at one point. So hopefully we can get down to that. So 50 acute patients, 10 in the ICU, and 8 of those on the ventilator. Still have 55 in that recovery period and 8 on the ventilator as well. Hays is doing better as well, 16 total patients with 10 of those in the active phase, so 6 in the recovery phase.
All right, so we are doing better overall. Yeah. We can hope that is. And we've had some good news over the last 24 hours with a couple more vaccinations. I want to say Novavax. I know that's not right because it's some combination of a bagel or something. Yeah, it's a vax. Novavax. It's not a bagel, it's a shot. So Novavax, and then J&J released their early results in a press conference. Both looked pretty good. I mean, the Novavax was up around 90%, but not as good against the South African variant. I think it was less than 50, or right at 48 to 50%. That's a 2-shot vaccination. Then J&J came in around 72% effectiveness with a 1-shot vaccination and about 57% against the South African variant. So let's talk about that for just a minute. So 2 more vaccines to go to the armamentarium. I think there's about 7 million doses to the U.S. for J&J, and there may be 100 million around April. So that's good news.
Yeah, absolutely. A couple things to say. I think this reinforces the fact that we've been asked this question, will we need a booster? I think because of the variants that are developed or isolated and identified, and as we are able to develop those vaccines against those variants, I think that will enforce what we've talked about, that we will probably need boosters of some sort. So
yeah, the other interesting thing is J&J is a 1-shot vaccination, and it was, I believe, 72%. Again, we haven't seen the data; it's just a press release. If you go back to the Moderna and Pfizer data, they were 60 to 80% effective after 1 shot. Yeah. It makes you wonder if J&J, Pfizer, and Moderna are all going to be in the 70% range for 1 shot, because it's kind of where they are. And then now they're saying at J&J, hey, we're going to go out and do another trial, and we're going to look at a 2-shot regimen and see if we can get over 90%. Okay, pretty soon it all feels like all the vaccines are going to be 70% with 1 shot and over 90% with 2 shots, at least between Pfizer, Novavax, Moderna, and J&J.
Yeah, and if you remember early on, we were saying we would like a vaccine efficacy of 50 to 55%. Well, I think we've been spoiled with Moderna and Pfizer, the mRNA vaccines, with their high efficacy. So if we can get above that 50%, I think overall for the global population, for the U.S. population, that's going to be a good thing. And then, of course, as the other vaccines are made available, we will have just more in that menu to give, especially certain populations. So I think that's a very good thing.
It is a good thing. The other thing is it does raise a question, and I know we've been debating it a little bit in the press, and it's been debated a little bit by the Biden administration and the government and with others, and we've heard about it on this program with Dr. Paulin before. Do you just give everybody 1 shot so you can get as many doses in, as many arms as possible, especially with the rise of the South African variant, because it becomes harder to spread when you've got hosts that are already immunized. So do you just give everybody 1 shot? I mean, well, if we have 100 million doses by April of J&J, we think we're going to get about 100 million doses of Moderna around then. The Novavax out there, I don't know how many they're supposed to produce. I don't know. We'll see what the AstraZeneca data looks like. But if we get, let's get another 50 million between that and those, if we had 250 million doses, and we could give all those before May 1st, should we do that before we start giving more second doses, I wonder? And I don't know. That's probably a Dr. Poland question, epidemiologist question. But it does make you speculate a little bit, because they're all going to be about that same level of effectiveness now. That's what the data is starting to show us. And I saw that debate beginning to rise late last night after the Novavax data came out, and I think it's going to pick up steam today, which way to go.
Yeah, and hopefully that will be a short-lived argument, as if more vaccines are authorized or even approved, so we will have more supply for those things. And I think, that first dose of vaccine really develops the specific immunity to coronavirus. And then I think that booster dose really makes that specific immunity more robust. So
Yeah,
that's
and I bet
the
we're
key.
gonna
The
wanna
second
get
dose
that.
is going to be the key. It's just a matter of when.
And I already saw J&J is going to try and reconfigure their vaccine to be more effective against South Africa. You know that Moderna and Pfizer already are working on that, I
Yeah.
bet. And the next question is, will they have to go back to the FDA to get more approval, or do you think they can just manipulate that, put that make the small modifications, and then just go ahead and put it out in public, which actually is how we do the flu vaccine anyway?
Yeah, and I think if you're just changing that one component, you're not changing any of the other components or ingredients in the virus, in the vaccine. You should be able to do it, just like you said, with the influenza vaccine.
Yeah, I bet that's where we're going to land, especially here in the midst of the pandemic.
Yeah.
You know what? We've got a lot of good questions. First of all, just two great guests. Amanda Cackler, our Director of Quality and Safety. She's going to be with us here in just a moment. And then Chelsea Smith, who from the Community Blood Center, is back on and talked about our need for blood, and an update on antibody testing. But before we go there, let's first see what we're hearing from reporters. Any questions? No reporter questions. Oh my gosh, I thought they would be asking about the J&J and the Novavax, but we've already covered it.
Yeah.
Because we're good. All right, let's first turn to Amanda. Amanda, how are things going out there?
Hey, things are going great. Very exciting as we're having all of these developments with the vaccines. I think Dana talked about this earlier in the week, or maybe you did, mentioning that our employees who have been vaccinated, we're starting to see more of them able to come back to work. So that's all great news on this Friday.
Hey, talk to us about the data around that, too, because I think it's pretty impressive. The folks who are being vaccinated aren't getting sick, and they're all coming to work. Talk to us, what's the change? What are the numbers like?
Well, I wish I would have been prepped for that question. I know that we hear that information every single day.
You mean I just launch things sometimes?
I do think that we were hanging around the tens and teens for our average number of folks that are tested daily with a new positive test. And I think that number has gone down closer to, I want to say, like the 6 and 8 range, which is fantastic news. And then our number of employees that are out due to either COVID itself or with a close contact has drastically reduced too. And that's been pretty consistent now for the last couple of weeks. So we're seeing some really good stuff.
I think I saw one day this week where we only had 3 new diagnoses of COVID positive, 3 or 4 in some employees. I thought, yeah, that's called vaccination. And unfortunately, we don't have everybody doing it. And some people are still contracting it early after the vaccination. I think those numbers are going to drop even further as more and more people get vaccinated. What percentage of our folks are vaccinated now here on the campus? Do you know?
I don't have that exact number. Again, I wish I'd have had that because I know I could get that information really, really quickly. I want to say we're in is it in the 70s?
I think it's between
70%
70 and 80. I saw somebody say 80%. I hadn't heard that. I thought we were closer to 70, 72%. But we'll have it, as Jill said, we'll have that next week, and we go through
We'll probably know in 30 minutes when we have our daily incident command meeting.
I bet you're right. Well, Chelsea, how are you? How are things at the blood bank?
I am good. Thanks for asking. Glad to be back. Things at the blood bank are better than the last time that I was speaking to you guys. So
good.
That's good news. We had a really good December, actually. We haven't had a good month in the year 2020. So December was exceptionally good for us. It really helped us get a bump up into our blood supply, but we're still not at that 7 days. We need to get back to a 7-day supply, and right now we're sitting about a 5-day supply.
Ooh, that is better.
Much better than the last time I was on, but
you were down to 2 or 3 days there for a while. That was a little spooky.
Yeah. Yeah, it was very touch and go for a while, and the 5-day supply is worlds different from where we were. You're seeing empty shelves. We still have empty shelves right now, but we are working on getting those filled back up. At least right now we have somewhat of a stock, and we're not having to turn around and send everything right back out as soon as it comes in the door. So a little bit of comfort there, but not quite where we
Dang it, sorry. Didn't silence today. Man, who did that today? Okay, sorry about that. I don't think I've had that happen yet before. Ha! Go ahead.
You're fine. Yeah, we saw a pretty huge bump in December actually because we started offering antibody testing for our donors, which ended up being a huge incentive for them to come donate. There are so many people who have been looking for that kind of testing, and we were able to obtain some funding to be able to offer that. So we offered that in December and January, and we were actually able to extend it a little bit into February as well. So we're excited for that. We're hopeful that that'll carry us through the rest of these winter months.
Yeah, that's a really big deal, and that's great to be able to offer the antibody testing. And now when we say a call to arms, I've got to remember we're going to give a call to arms for a couple of reasons. Call to arms to get your vaccine, call to arms to help us give a little bit of blood, which makes a huge difference, especially in places where they do, like, I mean, we do a lot of trauma. We really need blood for trauma cases, for major operating cases. Transfusions, of course, are a critical part of taking care of people. So, all right, well, I know we have a lot of important questions today, and we want to start getting into those. So, Jill, let's kick it off.
Yeah, and before we go to the printed ones that
Yes, sir.
we've
Yes, ma'am.
stockpiled, we have one or two that I think are kind of interesting and germane today.
Let's go.
Angie's son had to go to the ER. He had severe back pain. He'd been vomiting for 4 hours. They went in, they gave him a COVID test. It came back negative. They went through a battery of other tests and then came back to her and said, "We are sending you home with the diagnosis of COVID. We believe your son does have COVID. There just weren't enough antibodies." Or not antibodies, not enough of the virus showing. She wants to know, what do you think about that? Is that possible? Can you get?
Hawk, I'm going to go to you on that
Yeah.
one because that seems a little funky to me.
You know, it's always hard to make those assessments with our lack of knowledge and the specifics of that case and looking
Yeah.
at that medical record. I'm sure they did a full evaluation. I don't know if this was an antigen test or a PCR test. If it was if they were in the ER, it was more likely an antigen test, unless they were there for 18 to 24 hours within get a good or a quick turnaround on a PCR test. We know there has been false negatives on the PCR test, but and we know that COVID can cause GI symptoms, gastrointestinal symptoms such as nausea, vomiting, diarrhea. So it's really hard to make that assessment with this question right now. But we also have to remember there are other things that cause bad GI symptoms as well, and other viruses, and those are going around during this time also.
Yeah, for sure. It's not only COVID, but if you really want to know, you could wait about a week and go get another COVID check with a nasal PCR and find out. Yeah. Or if you want to wait about a month, you can go get blood at the community blood bank, and they'll do your antibody testing, right. And you can find out if you had COVID or not. But you got to wait about a month.
And I meant to say viral load. That's what the nurse told me.
Yeah, no, that's it. No, yeah, but it's odd. If you have enough symptoms to have all the GI tract stuff, you're probably shutting it for a respiratory tree. Yeah. And the question what Hawk was saying, did they really do the right test? I mean, not the right or wrong test. An antigen test may not be it's not as sensitive as a nasal PCR. And so the nasal PCR will pick that up a little better.
And then we just have a lot of chatter about that the viewers are reading that they're seeing that hospitals are having COVID deaths that they are attributing possibly to the vaccine.
That is just not true.
Yeah.
I do not know where that's coming from.
No.
We do not. I'll turn to all of us, but we have done, I think, was it 13,000 vaccinations so far? No deaths, right? Let's say it again. 13,000 vaccinations, no deaths from COVID vaccinations, and I've not seen anything ever reported by anybody.
No, correct.
Now, you can get a vaccination and then you can die. You may not die of the vaccination. You can only have a heart attack or whatever. And you can still get COVID, right? Because the vaccine is not, just because you get the vaccine doesn't make it immediately effective. Remember, it's 2 shots, 6 weeks. And then you can say you have 95% protection. At 2 weeks, you might say you have about 50% protection. So it's really not. I've not seen. I've not read. You and I, we all three stay pretty abreast of the medical information. I'm not seeing deaths from COVID.
There was that case of that. I think he might have even been a physician with the low platelets after the vaccine. I still think we don't know all the full details of that, but there may have been an underlying condition there as well. So I think, and we had Dr. Alt on yesterday, who said
CDC Advisory
no.
Committee.
Yeah.
Yeah, Amanda, anything else from your standpoint?
No, that is something that I look at every single day, and we certainly are having patients who are dying related to COVID, but we haven't had anything related to the COVID vaccine at this point.
Yeah. and I think the United States is over 400,000 deaths now for COVID. I'm thinking the real answer to the COVID vaccine is 0, so 400,000 to 0. Sounds like a Chiefs victory in the Super Bowl to me. Amanda, what are we seeing anybody? We haven't sent anybody to the emergency room after they get vaccinated. Any problems really from vaccination?
So from our employee clinic, we've had a couple of situations in which we've had reactions that need to be treated not because of their, like they're not having like significant respiratory problems or anything like that, but in the setting that we were giving the vaccine to our mass employee vaccines, you know, we were in the HEB educational building where we don't have additional medical supplies. So we would take them to the emergency department because maybe we had like a hive reaction and we just needed additional monitoring that we couldn't do in that setting. But we haven't had anything really significant in regards to an immediate reaction due to our vaccination.
Yeah. Yeah, I don't remember a lot of stuff either. So anything else from your standpoint?
No, I mean, we've monitored people right there as they've gotten the vaccine, but we expected that. We had that precautions taken, but as far as ED and anything, I'm not aware of that. So.
Okay, and I think we just got a little tidbit about what percent of employees?
Yeah, it sounds like about 80%, so it has gone up. We were at like 65 to 70, and we understand that there was across the nation of use, as you had talked about last week, at health centers and places like ours, about 70%, or there was a 30% vaccine hesitancy. So I think we've moved up from that.
That's really good. I suspect, Amanda, you've had a lot to do with that. How many people have you been out there trying to get arms on?
Well, we have absolutely had a lot of people helping every single day in our clinics, running Monday, 7 days a week during most weeks. And it's amazing the amount of folks that are just jumping in to help with that process. And we're really getting a lot of folks through there. So I've been over there several times. I've also had a couple of my sessions canceled due to the logistics. It's really challenging whenever you have confirmed vaccine today and then tomorrow you might not have any. And then the next day you've got another allocation. So it just adds to the complexity of the logistics that are already complicated to begin with.
Yeah, it's hard to get patients scheduled when you really don't know if you're going to have vaccine that day or not.
Exactly.
Yeah. So, Chelsea, how's the vaccination going over at the community blood bank? I'm trusting that you guys are considered frontline healthcare workers. Y'all have been vaccinated?
We did. We actually received our first round just last week.
Okay.
So we're in the middle of getting vaccinated over here. It's great.
That's outstanding. Good work. And I hope you guys get a good, there's going to be vaccine hesitancy out there. I know that, but hopefully up over around 80% would be, man, that's great because, we know that for a while we were around 61 and 62%. So we had to keep working at it.
And hopefully they can get back out. She had talked about early on in the pandemic when they were such low, they weren't able to go to those places of employment to do those blood drives like they were prior to the pandemic. Hopefully vaccination will also help them be able to get out there and these other places of employment be able to accept them to come in and have those donations as well.
Yeah. Are you guys still doing some good mobile clinics? How's that going?
Yeah, we're back out in the community and at the biggest capacity we can afford right now. We definitely don't have a lot of our corporate drives back just yet because all of those buildings downtown are empty. We're hopeful that this coming year is going to bring people back to the city. It'll bring people back to their offices to work where we can go and hold blood drives at workplaces again. But we are holding community drives, we're holding church drives, we're holding school drives. So that's been an incredible help as we're trying to build our blood supply back up. And it hasn't been something that we've been able to rely on for the majority of 2020. So we're hopeful that this will continue. We'll still have a lot of blood drives to go and pull from out in our communities. It's going well so far.
All right. Well, that's good news. And I'm just so glad to hear you guys are back to 5 days. But that's not good enough, people. We got to get to 7 days. Okay, Jill, first.
Okay, one more question,
Yes,
and then we'll go to our 10. And if we have time on the other end, we'll resume. All right. I want to give this question to Dana. She says, can you please explain the difference between dying of COVID and dying with COVID?
Okay, so boy, that we're gonna have to parse words around that. So, and I don't mean that negatively. It's an interesting question. So you may have COVID-19 and you may die of your underlying cancer, but the COVID-19 really was making you asymptomatic. You died with COVID, but not of COVID. The overwhelming majority, and I'll look at Amanda, she can help me with this too. The overwhelming majority of patients who are hospitalized with COVID-19 because they came in with that primary diagnosis. That's what brought them to the hospital. The rest of their health conditions then get compromised. And that's true with any illness you have. So if you have chronic obstructive lung disease and you have heart failure, you may go into heart failure, but that just made your chronic lung disease worse because you filled those lungs with fluid. So those two things, they go together. What happens with COVID is you may be fine in the community, but then you get COVID, and then all of a sudden your underlying health conditions can't tolerate the stress of that infection. The same thing's true with influenza. The same thing can be true with any other virus or any other infection. The problem with COVID-19 is because it causes such destruction to key organs like your heart, like your lung, then what happens is it throws those organs under bigger stress, which stresses the rest of your body, and then your body can't react. And most of the deaths from COVID-19 end up being respiratory deaths. That means that the damage to the lungs is so severe that you can't breathe well. There's some problems with heart disease, there's some problems with brain and others, but the overwhelming majority of this is lung disease. If you already have underlying lung disease, you don't have enough reserve. In each of the cases I've described, you really died of COVID. But your underlying diseases figured in to that death. So if you'd had normal lungs, you would have maybe survived the damage from the COVID. But if you have abnormal lungs, you don't survive the damage from the COVID. And a lot of it depends on just how severe the damage from COVID-19 is. Remember, even people with no underlying conditions die of COVID-19 because their disease has so badly affected their lungs and sometimes their heart that they can't survive. Okay, Amanda, Dana, thoughts around that?
The only thing I'd add, and I think you touched on this in the beginning, but we have had a handful of patients who've come in here after a traumatic event, like car accident or something like that, and it's just consequential that we've identified that they have COVID, but does it have anything at all really to do with their underlying disease there? Probably not. It was sort of something that we caught as a part of our admissions screening and maybe didn't play a role, but they now have died with COVID.
And in that case, the cause of death on their death certificate is trauma. Associated conditions is COVID-19. Otherwise, you may be dying of COVID-19 as the primary cause in your death certificate, underlying conditions, asthma, COPD, heart failure. And that's how we do the death certificates.
Yeah, and the same point goes to, we have, just as Amanda said, we have seen people who've come in with no symptoms from COVID, but later on while in the hospital, maybe for some other reason, develop those symptoms and develop those problems. Now, obviously, it's going to be better because they're here and be able to monitor it a lot sooner, and if they need to get remdesivir, they get it a lot sooner. If they need to get steroids or anticoagulation, they're getting that sooner as well. So you can come in and not have any symptoms from it, but on our admission screening, it's positive, and then later on develop symptoms and complications at that point.
And I want to be clear. There are theories out there that people really aren't dying from COVID-19 and it's not a bad disease. Those theories are just wrong. It's from people who don't want a mask, they just don't want to believe the obvious. People are dying of COVID-19. Make no mistake about it. Anyone tells you that's not true has not ever worked in a hospital, and they're just not. It's just not true. It's just wrong. Let me give another explanation. So I'm a lung doctor, right? We use this measurement of how much air you can breathe in and out in 1 second. We call it the FEV1. And it's a measure of, because of the way our bodies are built, we're able to move about 75 to 80% of our air out in 1 second. And that's because when you got to run away from a lion or a tiger or a bear, you got to be able to breathe your air in and out really fast. And so that's called your FEV1. Normally, as I said, it's around 80%. Let's say your FEV1's around 50%. Hey, you're probably not going to be running any marathons. Let's say your FEV1's around 40%. Well, okay, then you're not going to be running at all, and you may be able to walk, but you're not going to go real far. You get to 30%, and you're going to have a hard time getting across the room or going to the grocery store, and at 20%, you're going to have a hard time getting off the couch. And around 30%, we start talking about lung transplant. So if your FEV1's 50%, and somebody else's FEV1 is 80%, and somebody else's FEV1 is 30%, who's going to have the harder time with breathing if they get COVID-19? Well, obviously, the one who's got 30% lung function. The one with 50% is going to be a little safer, and the one with 80% is going to be the safest. So just think about it like that. You were fine until you got COVID-19. Not fine, but you were at your baseline medical condition. And then all of a sudden you get COVID-19 and your underlying disease is emphasized. That's why it's also could be true with influenza. But here's the difference. The risk of dying of COVID-19, whether your lung function is 20%, 50%, or 80%, is markedly worse with COVID-19 than it is with influenza, and 100 times worse than it is with, say, rhinovirus or something else. COVID-19 is the leading cause of death in our hospital. And a year ago, we had none. The risk of death coming into our hospital with COVID-19 is 9.6%. That is ridiculously high compared to any other condition. So the answer is you don't want COVID-19, and anyone who tells you that COVID-19 is really not that bad, they just don't know what they're talking about. They're just wrong.
We have one media question. Donna with Channel 9 wants to know, she met a man at a Super Bowl who said that he could take riboflavin and it would help prevent you from getting COVID and keep you well. She wants to know if that's accurate.
She met somebody at the Super Bowl? The Super Bowl was last year.
Last year.
Yeah, Chiefs Super Bowl. Okay. That's not true.
Yeah, I'm going to say that's inaccurate. There's no evidence of that. Riboflavin is just a B vitamin. So there's different B vitamins. A lot of people have heard of B12. A lot of those are in the 5-hour energy drinks, but it's a B vitamin. The same thing I think goes with zinc and vitamin D. You know, people are looking at these. There's no actual evidence, especially for now, riboflavin, that's going to help protect you or treat you if you get COVID. The best things you can do, again, are still going to be able to mask, distance, not meet in large groups. And if you get SARS-CoV-2 infection, it's going to be, as an outpatient, the monoclonal antibody. If you need to go into the hospital, it's going to be remdesivir. Steroids if you need an anticoagulation. So,
I have a couple of children with sickle cell. Will they be eligible to get the vaccine someday? Can adults with sickle cell safely take the COVID-19 vaccine?
Well, I'm thinking sickle cell, you'd want the vaccine.
Yeah.
For the adult. Now, the kids, we don't know yet because we haven't done pediatric trials.
right. And I think it was, 16 was the Pfizer?
I believe it's 16.
So, but-
Amanda, do you remember, is it 16?
16 is the right age, yeah.
Yeah.
But yeah, the ultimate answer is yes, if you're an adult with sickle cell, that's an underlying condition. You're going to want to get the COVID vaccine. And then as soon as it's available or authorized for children, I would certainly recommend it as well.
Yeah, I don't think the question is, can children with sickle cell get the vaccine? I think the underlying question is, can children get the vaccine? Because once it gets approved for children, I think it'll be approved for sickle cell, so we'd want you to have it. And those trials are starting this late spring, early summer, because I know we need to get Dr. Pahood back on and talk a little bit more about when those things are, what's going on, because I know Children's is a leader in those trials.
My relative had the Pfizer vaccine. She and her boss, after 2 weeks, have not shown any antibodies when tested. How long does it take for antibodies to show after the vaccine?
Yeah, my question is, why were you getting antibodies checked after 2 weeks?
Yeah.
Because that's early.
Yeah, so for a lot of infections, we don't have what we call test of cure. And for this vaccination or other vaccines, I would not say that we do test of immunity. In this case, against the Pfizer and Moderna vaccines, I would say you don't need to be testing for antibodies. The other thing to consider is, what was that antibody test? I know for a fact that here at our health system, the antibody test that we use does not test for spike antibodies. It tests for an antibody that you develop if you've actually seen the virus. It's another structural protein on the virus. So even though I've had the vaccine, I would test negative for that antibody test because I have not had the SARS-CoV-2 infection. I have not had COVID-19. So you have to understand, what is that antibody test? What antibodies are they testing?
Yeah, so because the Pfizer and Moderna vaccines are really going to produce antibodies to the spike protein, if your lab checks an antibody to a different protein just because you had the vaccine, it doesn't mean you're going to test positive to that protein. You would have had to have COVID-19 to test positive. So that's a really important point. And even if you've had the vaccine and you go get blood, you may not have antibodies. So
And ours checks to the N protein. So.
Okay.
Donna Pittman has a follow-up question to the sickle cell. She's with Channel 9. She said, does that also include sickle cell carriers? Are they considered, would that be considered an underlying or comorbidity?
Yeah, I don't know about sickle cell carriers.
Yeah.
Do you?
I think carrier, you're heterogeneous.
Right.
Or heterozygous, not homozygous, meaning you have both of the traits.
Right.
But again, I don't think that matters. I think everybody's going to be needing
Everybody's going to get
the
vaccinated,
vaccine, and
yeah.
it will be safe for
Yeah.
those for that population as well.
And I think for all the reasons we've described early in this program, I think beginning in April and May, this major shortage we've experienced will translate into a different problem. The new problem is going to be getting it into arms because we're going to have vaccine. Right now, the problem is, we explored this the last couple of days, when people are so frustrated. I understand why you're frustrated. The problem is there's no vaccine, and there's a whole lot of people who want to get it. Come April, May, the challenge is going to be getting it into people rapidly enough, because I think we're going to have a lot more vaccine. So we've got about 2 months to really plan for that. And we're going to have a little bit of vaccine coming in during the interim, and some may begin to escalate in March. But the reality is, come April, I think we're going to start seeing a lot more vaccine, because I think Novavax and Johnson & Johnson and Moderna and Pfizer will all be in the market. And maybe AstraZeneca, we'll know that data in March. But so hopefully. And Amanda, are we going to be ready for these big vaccine clinics?
I think we will be. You know, we are, we at the main campus and at our Indian Creek campus have some space that we can use to have that large volume of folks come through. But I do think the logistics of getting the amount of people through a vaccine clinic safely is something that folks are going to be challenged with. When you think about how do you get people to a large room or into a clinic setting when you've got stairwells or you've got elevators, or you're the last year we've been trying to not get people to congregate, and we've been limiting visitors, and now we're inviting a whole bunch of people into a location for something very, very important, but we still want to be safe in doing so. Something that we've seen, and I believe Kim Dixon and Adam Meyer have probably shared this, this is an instance where you want to show up at the time of your appointment and not any earlier, because if you come in early, and we've had people show up 2, 3, 4 hours early, now you have to account for an additional body that you have to make sure you have good social distancing practices with. So it does add to the logistics of administration.
Yeah, that is a challenge, and I know, because it's different in different places. There are some of those mass vaccine clinics, you're in line for a long time. Others, because you're here, you're parked in the parking garage, you get you in, you stage them on the second, you get them up to the 6th floor, and they get their vaccine, and then they get out. And so, and my arms are directing that so well. But I think that we're pretty well organized around that and can do that in a very timely fashion. So, okay.
Do people who do not have insurance qualify for monoclonal antibody infusions?
All right. I think we actually had to work on that question, because we had to do some homework. And in all honesty, our team did the homework. So I've got the answer here. Yes, uninsured patients are being screened and treated for COVID. We can apply for reimbursement under the HRSA COVID-19 uninsured program. That uninsured program will takes a reimbursement for monoclonal antibody therapy with the guidance from November the 10th of 2020 per CMS's Medicare monoclonal antibody infusion program instruction during the COVID-19 public health emergency. Medicare will cover and pay for these infusions the same way it covers and pays for COVID-19 vaccines, because we are giving them with the EUA. So the answer to the question is, we believe we can infuse monoclonal antibody even in people without insurance. Okay, I'm looking at my team.
Yeah. That sounds great.
Amanda?
Have anything else to add to that? Good research.
Oh, no, I didn't do this research. I want to be clear. Jill and team did the research, so thank you.
Should kids at school double mask?
Amanda, what do you think about the double masking? I'm curious to see what you say.
I know that Fauci said that it makes common sense that it would provide additional protection. And I think the context of that is really important.
Yes. We
have, again, demonstrated over the since last March, that a single mask is effective in preventing the spread of COVID-19. I have seen people double mask in the healthcare setting and in the public. And I think it's kind of difficult to breathe through one mask, so adding a second mask may make it difficult, especially if you have an underlying breathing condition. So the question about should kids double mask, I don't know that there's truly a significant benefit, or that it's been studied enough for us to say that it's better than one mask. I think we really need to be focusing on just a mask at this point, or some kind of barrier coverage.
And we do have data that when precautions are taken, and engineering precautions and masking, those things are done in the classroom spread of disease is extremely small compared to out in the community. I would rather emphasize that the adults in the building don't meet together with their masks off, don't eat together in closed spaces, things of that nature. Keep themselves healthy, because I think we have seen pretty good data that when schools are opened up, the school itself, there is very small spread, very little spread in the school itself. It's all the other community things, meetings, extracurricular activities, house parties, things of that nature. So, but I think in the school itself, the children do not seem to be spreading it or getting it as much as other places in the community outside of that building.
So, okay, I'm going to extend that question to you both just a little bit. I know this is like the third time I've hit Amanda from some weird outcome. Here we go, guys. So you're starting to see people talk a lot about the variants, and maybe we should have more aggressive masking and even N95 or K95 masks. Yeah. I saw there was one comment, and I don't remember where it was from, but it was from a public health person talking about, gosh, should we be wearing N95s now at the grocery store because we're worried about the variant? What's your guys' take on that?
I'm going to say no, not given the information that we currently have available. Again, I think we have seen it work, that if you have good social distancing, if you're wearing just the regular barrier protection or the source control, that we're able to stop the spread until further data comes out suggesting that absolutely it can be spread even with those precautions in place. Then I probably wouldn't jump to everyone in the community wearing an N95. And again, we do know that there's situations in the healthcare setting where an N95 is absolutely appropriate, and we need to make sure that we continue to have those resources if additional surges come.
Yeah, you know, the more transmissibility hasn't really been elucidated or further characterized. What we think it is that the binding of the spike protein to the receptor might be tighter. So you're less likely to, say, have the virus if you do inhale some proportion. We know it takes very small amount of viral particles to get infection, but if you do inhale it, there's a chance that it could be binding tighter to that receptor, giving you infection. The other thing from a recent study, a phylogenetic study, meaning they went back and looked at genomes that they have available in the United States back through November, and it looks like the B117 or the UK variant may have been circulating in the United States even as early as November. But even in those states where it was introduced, I believe in California and Florida, as of early January, even though it was introduced in November, it still only remained about 0.4% of cases in California and about 0.6% of cases in Florida. So, you have almost 2 months there where you didn't see large spread like you saw in the UK. So I think, to Amanda's point, if you're doing the masking properly and being vigilant about it and not meeting in large groups and keeping your bubble where it is right now and distancing, you should be able to protect yourself from even the variants, because we don't believe the virus hasn't changed in size. It's not smaller. The droplets that people breathe out are still the same size. Now, maybe there's higher replication and there's more viral particles in those droplets, but the droplets themselves are going to be the same size. The virus is going to be the same size. It's not going to be able to filter through the mask anymore. So I think one mask right now is good. I'm not going to discourage 2 masks, but I'm still wearing a single mask.
I'm doing 1 mask. I think the people who need 2 masks are the ones who can't seem to get 1 mask to fit over their nose. I think in that situation, they need 1 for their mouth and 1 for the nose, and then I think 2 masks are okay. The other thing I would say is if you're ever going to do an N95 mask, I'm always nervous when people put another mask over the N95 mask, because you can defeat the N95, the seal around the N95.
And I think, we've always encouraged eye protection, so I do see people out in the community wearing face shields. I'm on board with that as too. I would definitely encourage a mask and a face shield, or a mask and goggles as well. That's one more part of protection.
Yeah, I've had 4 eyes my entire life, but if I'm in a crowd, I'm going to put on my trusty eye shields. Whoa, wait, I got an extra mask in there. That's for when I will leave home without my mask and I forgot where it is or something, or I get it wet. There we go. I look so good. It's the best.
That's good.
All right, next question.
Is there concern with the AstraZeneca vaccine being only 70% effective compared to the 95% effectiveness of mRNA vaccines? Will the difference in efficacy slow herd immunity or give the virus more opportunity to mutate? And for bonus on this, the crowd today, Kathy and others are asking, first you said don't mix them, now you say it's okay to mix the mRNA.
Oh, no, we didn't say it was
Nobody
okay to
said
mix
that.
them. No, we did not say that.
No.
Not us, maybe then, but people are saying.
Well, we can clarify that.
Yeah, we'll
Yeah,
clarify that.
all right.
Okay, go.
Well, I think, remember, we were pretty happy when people, those vaccines were first coming out, if we can hit 50 to 55% efficacy.
That's influenza.
We've been very lucky to see the mRNA vaccines show 90+% efficacy. So I think we're ahead of the game there. But remember, there are storage problems and transport problems with the mRNA vaccines because of the cold storage that you need. Pfizer certainly more than Moderna. The AstraZeneca vaccine, it's a little bit more stable. It can be used a little bit more places. So as Dr. Pahoud had said when she was on, it's going to be more of the vaccine for the world. So I think if we have several different vaccines in our armamentarium, use them in certain situations, I think it's going to be good. I'm not concerned with that at all. I say get what you can get right now, because even 70% or 70+% is going to be a lot better than nothing and getting the disease itself. As far as mixing the mRNA vaccines, you probably can do it. The guidance from the CDC says in exceptional circumstances. But if not, if you can't get that second dose initially, try to hold off, because we know you can delay that second dose until you can get the same company that you had on the first dose. So we are not changing our guidance there. We do not want to mix. There isn't a lot of studies about it. Is it okay? We just don't know. It could be,
But even
we
more
don't
clearly,
know.
you should not mix, say, a Johnson & Johnson, which is an adenovirus vaccine,
Yeah.
with a Moderna vaccine, which is an
Correct.
mRNA vaccine. Those are different mechanisms.
Would not advocate that at all.
So there should not be an added effect. Amanda, anything else around that?
No, and I think, again, that it adds to the layer of complexity in the administration logistics is that, and we've actually safeguarded that here by making sure that we have staged areas where only one manufacturer vaccine is available in a certain spot. So if you had Moderna, you go to the Moderna side. If you had Pfizer, then you go to the Pfizer line, so that we are ensuring that folks get the same manufacturer with their first and second dose.
The thing I would say is we haven't seen the U.S. AstraZeneca data. So we're talking about world data when people quote 75% for AstraZeneca. And we'll know more about that over the next few weeks. The Novavax and the Johnson & Johnson data, which are coming in, or, the Novavax 90% and Johnson & Johnson 70, 75% or whatever. The problem is we don't know what that means yet. They've just said it's 70 or 72% effective. What they haven't explained is what effective means. I don't know what the definition is. It means you didn't get seriously ill, or does it mean you didn't get ill at all? Because if the devil's in the details. If on the Johnson & Johnson vaccine, 90% of the time you don't get seriously ill, and 75% of the time you don't get ill, well, that's still really, really good.
Yeah.
But we don't know what level of illness is. We haven't seen the raw data, and that's going to be out next Monday and Tuesday.
And I think that's a great point. I did see one line in that earlier press release
too.
that it protected against severe disease, and that's what we're hoping for as well.
Yeah.
So, but that's a different level as well. I think that's a great point that you bring up. Yeah.
Okay.
Where can someone go to be assessed for long hauler symptoms if they are not a patient at the health system?
I don't really know the answer to that question. I'm not sure we do. You could probably Google it and see. I think eventually our long haul clinic will open up to the public as we get more capacity. Right now, we're just doing it with our patients. I suppose you could try to become a patient at the health system for some other reason, and then you can go to long haul clinic. But eventually, we'll open it up. We just don't have the staffing to do that yet. We got to get people in place. Remember, the people who are doing our long haul clinic are all folks who already had a busy clinic, and they're taking it on top of their already busy clinical work. As we get new hires in and new people going, we'll be able to, our goal is to broaden the long haul clinic and its multidisciplinary reach.
Yeah, definitely. We had a meeting about this week. The plan is to open it up to outside referrals, and we would like to do that and help as many people as possible. But to start, I would start with your primary care physician.
Yeah.
What are your symptoms? Let him or her identify those. If there are things such as malaise and fatigue, they may be able to take care of it. If it's other things such as shortness of breath and cough, you may want to get referred to a pulmonologist. But our plan is to open up to outside referrals.
True or false? I read that you shouldn't take anti-inflammatory drugs prior to getting the COVID-19 vaccine.
Okay, I'm going to look at Amanda and at Hawkeye here, because I'm going to say guilty as charged, because I know how I feel after vaccination, so I tend to take them. What do you guys think?
Yeah, I would agree. I would say false. We've had plenty of folks here who've taken anti-inflammatories prior to their vaccine experience because they've had previous side effects that they wanted to prevent. So I think it's we haven't seen any reason why you couldn't take something before you get your vaccine.
Yeah, I mean, I would agree with that. You know, there are some articles in the mainstream media where some experts are saying we don't want to do it. There's really no data about this. I actually had a discussion with Dr. Alt as well. This was discussed in his ACIP meetings, in his emergency meetings as well. No good data. There's some pediatric data with pneumococcal vaccine. That's not what this is. I can't envision a mechanism as to why taking 8 hours or 24 hours of Tylenol or ibuprofen is going to dampen that immune response. Yes. If you remember, you get the vaccine, it gets into your muscle cells in that interstitial space. It then drains to your lymph nodes. That takes more than 24 hours. A lot of the reaction, the immunity that you gain is occurring in that lymph node where you're having the B cell clones and the T cell clones develop and make that specific immunity, and that's going to be happening over more than 24 hours. So, taking 8 to 24 hours for symptom relief is probably not going to affect reactogenicity or immunogenicity of the vaccine.
Oh, I'm taking mine next week. And by the way, I think there's a certain somebody getting their shot on Monday. Now, I understand that there's spike proteins in the world, and then we had a viewership spike every time Hawkeye gets a shot. I don't think that's probably going to happen with me, but I told you I was going to talk about that. I warned you. Something about that. I don't know what it is. Maybe because my biceps is not, maybe a half the size of my partner's.
Dr. Stites, I would not underestimate your charm.
Yeah, well, charm and biceps may not always be the same. Okay, next question. I'm properly embarrassed.
With 1 in 13 people testing positive for COVID-19, is contact tracing still happening?
Yeah, it is happening.
Yeah, Amanda, we still doing it?
Yeah, we are absolutely still doing it here at the health system, and health departments are continuing to do it out in the community. It's still an important component of preventing the spread of transmission, and quarantining is still a thing that we do when we have known positive contacts.
I know I'm staying home all the time
it's
anyway.
Being done.
So.
It's being done. At the community health level, we know that with K Athletics, it's still being done. So contact tracing is still being done.
It is really important. Yep, and it will be really important, especially with the variants. And as we get into that, we got to really contact tracing some of these more widespread variants.
2 more questions. I have Hashimoto's disease and worry about taking the COVID-19 vaccine. How will it affect me? Any advice to minimize potential side effects?
It's you, buddy.
Well, I think it'll affect you the same way it affects anybody. You may have some mild symptoms, moderate symptoms. You may not. It just depends. But it will be safe to take. I don't think you are going to be any different than any other individual who's getting that vaccines with your Hashimoto's disease.
And last question for today. Why do some people have worse symptoms after the first dose? What's happening? And what does worse mean?
All right, what do you think, Amanda?
Well, I think that's an interesting question, and we have seen a lot of variability in people's response to the vaccine. I know in my case, my first dose, the only side effect that I had was the localized pain in my arm. It was more extensive than I'd had with a tetanus shot or with a flu vaccine, but it went away within 24, 48 hours. And I've heard other folks who are down. They feel extremely fatigued. They've got chills. I've had someone on my team who had a fever after their first dose. It's really relative to each individual person and how they're going to respond to it. So it's hard to predict. And, my pain was tolerable, and maybe to somebody else it wouldn't have been tolerable. So it really is dependent on how you respond to the vaccine.
Yeah, I think so. And side effects are side effects, but the real key is the side effects of COVID-19 are far worse than the vaccine.
Yeah, and I think one thing to remember too, I was listening to a podcast last night. They talked about the smallpox vaccine. I'm too young, I didn't get the smallpox vaccine. But from what I understand is when you did, it caused a pretty bad reaction on your arm with purulence and pus and scabbing and things like that. So we have become, maybe more harder to take side effects. But certainly I think the side effects that we're seeing from these vaccines now, and that includes tetanus or influenza, are certainly not what they were from vaccines prior to this age. So we have to remember what it was like to get those types of vaccines as
So
well.
I have a scar on my left arm, left over for the smallpox vaccine. And when I was a young man in medical school, if somebody couldn't remember, you just looked at their arm and you looked at where you know they had it. And they had that little ring and a little depression. You're like, yeah, here's your smallpox vaccine. Yeah, I got one of those. Hey, on Monday, the presidents and CEOs from the Kansas Hospital Association and the Missouri Hospital Association joined the update. Chad Austin and Herb Kuhn will share the pandemic impact on hospitals on both sides of the state line, the impact of President Biden's health agenda for Kansas and Missouri, plus how COVID-19 is affecting the appetite and status of Medicaid expansion in both states. Well, I'm sure we'll be talking to them about how we're going to distribute vaccine in both states as well. Final thoughts today. Let's first start with Chelsea. Okay, Community Blood Bank, a special plea. Oh, Chelsea's off the Chelsea, I'm sorry we didn't get back to you soon enough. Thank you for being on the program today. I'll say to all of our listeners out there, please think about donating blood. You can go down to the Community Blood Bank and do it. They are special people. They have a special mission. They do great work. Amanda, final thoughts.
Yeah, so I know this probably is going to be more relevant next Friday, but folks are starting to gear up and plan for Super Bowl Sunday. And I think I know it's so exciting. I mean, this is our second time back there, and we just have to be extremely careful with the size of gatherings that we are planning, and if possible, keep it to your local bubble. Those pillars of infection prevention haven't changed even with the vaccine availability, and even with exciting things like the Super Bowl, we just have to not let our guard down.
Yeah, to piggyback on that, I would say, in this weekend and moving forward, everybody continue to understand your bubble, distance, not meet in large groups, so that you can be healthy and be at home and watch that Super Bowl, so you're not in the hospital or sick or feeling otherwise bad. So I think it's important moving forward so that you can have your eye on a week from now when they're playing, and you can be healthy and happy watching it.
Super Chiefs taking down the Bucs.
That's
hey,
right.
But I do have to correct you one thing, Amanda. It's our third time back. I was a 6-year-old for the first one. I don't remember too much. I do remember the one I watched when I was 9 years old, though, in 1969. Actually, it was 1970, and when we played. But I remember being a nervous young man. And then last year, I was a very nervous old man. And I'll be the same one today. Hey, Hawkeye and I and our team are looking forward to the Super Bowl. We want to know what favorite fan food you will be serving in your bubble. In your small bubble, don't make it a big bubble, just like Amanda said, what she said. Send us your favorite Super Bowl recipe. Here's the catch. It has to be heart healthy. And if I'm going to eat it, it's got to be low salt, not have garlic in it. I'm really boring. I'm sorry about that. It must be heart healthy because we're heading into February. Send us something tasty. We're going to pick 2 recipes, and our health system chef will cook it. And they will share it on Red Friday, so you can know what it is, and we'll tell you what it is, and you can have time to make it for your guest. We're going to be eating it right here in the studio, non-Red Friday. I'm going to be wearing some Chiefs gear. I know that's hard to believe. And we will talk about how to celebrate safely and with healthy food. Special thanks to all our guests today, to all of our listening audience. Stay safe this weekend. Remember that even as we get so excited about the pillars of infection control, you should know what I'm going to say next. We get so excited about the vaccine. The pillars of infection control travel with you wherever you go. Wear your mask, wash your hands, gather only in small groups, stay inside your bubble, take your temperature, if you don't go out if you're sick. Remember, there's still no place like home, because you want to be here when your call to arms comes, and it is coming. Have a great weekend.